Well, I'll start with actually, I didn't get a lot of sleep last night. We're getting towards the end of the conference. We've had lunch. I think everybody's kind of tired. Chris did a great job getting people to stand up. I'm going to do the same thing. And I'm going to start by asking you to stand up if you consider yourself a logistics or supply chain professional of some sort or another. Now, from those of you standing up, what if I asked you, if a woman came in here seeking some family planning services, and I asked you to show her the range of methods that were available, help her select the one that was appropriate, and if it were one that needed to be injected or inserted, to do that. Stay standing if you would be capable and comfortable doing that.
Including inserting it?
Including inserting it. So we have 2 people standing, or is it 3? One very tall and 2 behind. Okay, thank you. You can sit down now. Now, by show of hands, from all of you, who thinks that's a crazy question to ask a logistics or supply chain professional to manage that kind of clinical service? So, exactly. I'm going to talk to you about a model that's very similar to what Wendy talked about, that we're using in Senegal for contraceptives that looks at distribution in the same sort of thinking. And it's called the informed push model. So to start with the context, the contraceptive prevalence rate in Senegal is very low at only 12%, and the government has a goal of 27% by the end of next year. Unmet need for family planning is at 29%, and stockouts were rampant at about 80% throughout the health system. And despite a lot of efforts to improve the supply of contraceptives at the national and regional level, there were stockouts persisting at the service delivery points. So this is, again, very similar to what Wendy just presented of what is the informed push model. We have a standard system here that's shown where orders are placed from the service delivery level at the bottom there. They place them to the district, and then the district orders from the regional level. And this problem is full of problems, like the health worker at the service delivery point doesn't have the quantification skills, just as most of us don't have the skills to insert an IUD, for example. There were problems with cash flow because it is a cost recovery system, which is common in West African countries. Insufficient staff capacity to manage the supply chain, and no data. In Senegal, the specific context is also that there was a 3-year-long data strike where the health workers continued to provide care but did not send any data. So the informed push model was the response to this. And essentially what that does is using private sector, using a third-party logistics provider, deliver contraceptives from the regional level directly to the service delivery points on a monthly basis using specialized logisticians. So for those of you who are coming to this conference from a human resource perspective, I'm going to sell you this model as task shifting from overburdened, untrained health workers to a specialized logistician with the skills and competencies required to do this job. From those of you coming from more of a supply chain angle, I'm going to sell this to you as a vendor-managed inventory, outsourcing to a third-party logistics provider, and level skipping system. So what is this third-party logistics provider doing? They're managing the quantification and ordering process, so the service delivery points are no longer ordering. They do the transportation. They collect data from the service delivery points, so no longer is the storekeeper expected to submit that or collect and submit that data. They still have to fill out a stock card, but they don't have to manage all that data collection. And they also operate a temporary store. Basically, they get the contraceptives from the National Supply Pharmacy and keep it just for a few days as they prepare for the deliveries. This, just as Wendy said as well, frees up health workers to provide health services. We're working on the national expansion of this, and at a national level, it would require about 1,450 health workers to be trained and supervised on non-clinical tasks, on these logistics supply chain tasks. Afterwards, it's 14 3PLs. And in fact, it's less than 14 because we have one 3PL that serves multiple regions, the same company. And then who are the 3PLs? They're local Senegalese companies with logistics professionals. They are not UPS. They are not FedEx. They are Senegalese companies. Some have connections to companies in Europe, but for the most part, they are local people. One of the first ones that we had actually is a man who worked in logistics for Nestle for 11 years and then started his own company. They are paid only for the time that they work, so we don't pay for them on the days that they're not doing a delivery. And they are actually significantly less expensive than managing the transportation distribution with in-house resources. So with the staff, the vehicles, and all of that of the National Supply Pharmacy. Where are we with this? Everything in orange there on that map, including the stripes, is where this model has been implemented. So we're 9 of 14 regions, and we expect actually to be in the remaining 5, the gray ones there, by the end of the year. Total stockouts have been reduced from 80% to less than 10%. There are some specific problems that this system solves, specifically transportation, quantification, and financial flows. So when we look at the stockouts that are caused by those things with the system, it's less than 1%. The other stockouts that we found have actually been because of insufficient stock, expired stock without sufficient stock to replace that, and then sudden spikes in consumption. And when I'm talking about stockouts, I'm talking about all stock available at the service delivery point, not just what's in the store, but everything that a client would have available to them. Consumption data went from 0% to 100%, again, because we essentially outsourced that data collection as well as the distribution. And then I have some examples of increases in consumption here, just over a 3-month period earlier this year, an 11% increase in consumption of depot and 14% in the pill. So now a little bit more on results from a qualitative perspective. I put this quote up here because I hear this all the time. Every time I do a field visit, I hear that the IPM is a revolution. They always use this word revolution because it has completely changed their ability to provide services for family planning. More qualitative results. Increased satisfaction with family planning services. So the product availability saves money. People no longer have to go to the private pharmacy to buy their product. Improved workflow. If it weren't for the push model, I would have to close my post today and go to collect medicines. Instead, I can stay at the post and have the medicines come to me. Better quality of data. IPM helps us with data management. The family planning forms are filled out well and up to date, unlike the forms for other products. And I want to emphasize on that last one. This is not because this is an NGO project. It's not the NGO who's actually doing that. It's the 3PL who's doing that data collection and submission. For some lessons learned, IPM strengthens public-private partnerships while aligning supply chain incentives to ensure availability at the service delivery points. One of the beauties of having a cost recovery system is that everybody within the supply chain is incentivized to make sure that products are there and actually distributed or sold to clients. Through these improvements, we have the potential to boost health worker retention, improve client satisfaction, and increase access to contraceptives. And shifting non-medical tasks from health providers to logistics professionals improves service quality, supports the cost recovery, and provides women with a full range of reproductive health choices. What's not on here that I do want to emphasize as well, actually, on a lesson learned by working with 3PL, since there was a lot of discussion this morning about engaging with the private sector, is that one thing that we've really found is that it is really important to have an interface between the very fluid, dynamic environment of the public system and the fairly rigid private sector. So what we have employed by the NGO for this project, we have a specific position, an assistant logistician, who manages that relationship. They also have to be, it's more of an art than a science, because we need to be somewhat flexible with these 3PLs as new products are added. They need to be flexible with that as new service delivery points are added or some are taken away. They have to be flexible to work with those changes. Yet we also need to demand high performance from them. So we do have performance-based pay contracts. Are they always enforced? Not 100%, because we need to have some flexibility with them so that they'll be able to work with us. If they made us change contracts every time a new product was added or taken away or a new service delivery point was added, it would be a nightmare and it wouldn't work at all. So we have to have that kind of flexibility. Next steps, as I already mentioned, expanding to the remaining 5 regions by the end of this year. We're able to do all this expansion because it was included in Senegal's National Family Planning Action Plan. So essentially, before this expansion project started, they had changed the policy to use the informed push model for family planning distribution. We're also looking at the integration of other products. And in this case, I think it was Chris who said earlier today, integration doesn't always mean throw it on the same truck. This is kind of what we're talking about in this case. Our first priority is the UN commodities for UN Life-Saving Commission, all of that stuff that's on the wall over there, those products. But integration is a huge challenge. There's a lot of work to be done for that, and there's a lot of kinks to be figured out. And I think a lot of people actually say, hey, you fixed stockouts for family planning. Excellent, I need my products on there. Well, this model solves some very specific problems. And if your products don't have those same problems, this isn't the right solution for you. And that kind of analysis needs to be done. And our challenge right now in Senegal is to be able to communicate that well. The PNA, which is the National Supply Pharmacy or the Central Medical Stores, has agreed to be the long-term implementer and manager of the model after the project ends, which is a huge responsibility that they've taken on, and they've extended their mandate in doing that. So in that regard, we have one region, which was the striped region on the map in the very north of Senegal, that's being implemented by them now. And they have included this in their strategic plan to be able to take it over. So thank you very much.